Welcome to another case review session from the Menopause Society on News and Health. I'm Shiona Khan, I'm a medical writer with News and Health, and we're really grateful that you can join us this evening. We hope you'll find this session informative and useful, more importantly, for your clinical practice. As always, we're really grateful to the clinicians that give up their time to volunteer to present one of these cases. They're talking from their own knowledge and experience. And during the session, if a question pops in your mind, you can write it in the Q&A. We'll try and cover as many as we can after Karen's given her presentation. And you can vote for a question as well if you see one in there that you'd also like covered. If you'd like to speak to Karen directly, you can raise your emoji hand and then we can turn your camera and mic on if you want to do that. And that part of the session, the Q&A, is not going to be recorded. Now I'd like to introduce Dr. Karen O'Reilly. If you don't already know her, she's a GP that has worked in Hampshire for over 30 years. She's also a GP trainer and examiner for RCGP, and she has joined the News and Health Clinic as one of the menopause specialist doctors in the last year as well. Karen has an interest in women's health and mental well-being, and she's going to present a case this evening about a 42-year-old with predominantly psychological and cognitive symptoms, and it highlights factors about prescribing estrogen and testosterone, as well as providing a bit of a recap on POI for us as well. So thanks very much, Karen, and I'll hand over to you.
Thanks, Shona. Welcome everybody. It's great that you've been able to come along this evening, and hopefully you'll find this useful. So as Shona says, I'm a GP as well as working in the menopause clinic. So I'm going to be presenting this case because I thought what it points out is something useful with my GP hat on, because there are areas that when I wasn't working in the menopause clinic, I found quite difficult with my GP hat on. And I still can remember just about what it's like to be a GP because I still work in general practice. So I'm presenting a case which now won't move. Hold on, how do we do that? There we go, Amira. So this lady is 42 years old and she's an estate agent, and she went along to her GP complaining of couldn't sleep, anxious, irritable, low mood, not feeling herself. Periods were still heavy, but a little bit irregular, loss of libido. And her GP very sensibly took the history, examined her, and decided to run some baseline blood tests, as I think, most of us would, to keep sure she wasn't anemic, it wasn't thyroid or anything, and they were all fine. She did query whether it might be anything to do with the menopause, but the GP was very reassuring and said, you're still having periods, you're only 42, you've got no hot flushes or anything, so I'm confident it's not the menopause. And I'm certain that this is something that we have all done at some point. And what seemed far more logical is that she had a very busy life. She worked full time, ran a home, husband worked away a lot, and she had two fairly, children at that demanding point in their lives where they need to be taken to X, Y, and Z place after school. So the symptoms were very much put down to stress, low mood, and she was started on sertraline. And I know certainly from my own experience, I'm sure this is a pathway that I've gone down numerous times before with women in their early 40s. So she tried the sertraline, several months, putting the dose up, there was no improvement. And she just happened to be seeing a program about the menopause on TV. And it sort of occurred to her again that actually that she could be menopausal. So she went back to the surgery, and her usual doctor was on holiday, and she saw a different GP, and she asked whether she could have her hormone levels checked, which again, in general practice, is a very, very common request from patients. So the GP very kindly agreed and did her FSH and her estradiol. And Amira was told that, her FSH was only 12. So this was really reassuring that it wasn't the perimenopause. And so again, very reasonably suggested a change in antidepressant, but Amira didn't really fancy that. So she came along to see me in the clinic, and, with the benefit that the GP had already taken the history, had already tried antidepressants, had done some baseline bloods, it was relatively easier for me to be able to clinically agree that she very much fitted with the description of being perimenopausal. With the ladies we see in the clinic, we ask them to do something called a menopause symptom questionnaire, which is an attempt to objectively try to quantify their symptoms. And the maximum score is 72, minimum score is 0. And I know it's not really something that we use routinely in general practice, but it is available on the Balance website if anybody did want to give it to patients. What's quite nice about it is it's actually quite a nice way to see how much they improve. So her menopause symptom score was 36. We always check all the other things about lifestyle, that there are no major risk factors for starting HRT, that they're up to date with everything. And of course, Amira was. So I thought it was pretty straightforward. I'd start her on some estrogen gel and some Utrogestan. She was still having periods, so she needed to have a cyclical regime. Her husband had had a vasectomy, so I didn't need to worry about contraception. And I agreed to see her again in 3 months' time. Seemed terribly, terribly straightforward. A little note about contraception. We all have our little areas of medicine that worry us more than they should, and contraception's one for me. Somehow in my mind, if I use the word menopause or perimenopause, I think the woman is older, and I then sometimes make the automatic inference that she doesn't need contraception or she's not sexually active. And having come across a lady many years ago who ended up in the antenatal clinic at the age of 51, having been given some HRT, I just always feel quite paranoid to know that these ladies have got contraception. So just a word about, don't ever forget that, because HRT is not contraceptive. This is just a copy of the menopause symptom questionnaire that we give to ladies, and they just fill this in themselves, and we get them to do it again at the follow-up appointments. And it's really nice when we see that their score may have gone from sort of like 36 to 2. It's a sort of a quantifiable way that they've improved. So I thought that was all fairly straightforward, and I was going to see her again in 3 months' time. But after about 6 weeks, she made a call to the clinic, and she said she was actually starting to feel worse. She was starting to struggle at work. So I very generously, I thought, said, well, go up to 4 pumps. You're only a young woman. You probably need some more estrogen. And again, I thought that was fairly straightforward, and I agreed to see her again in a few weeks' time. Well, by another 6 weeks had gone by, she contacted us again, and her menopause symptom score had gone up to 42. And she was really starting to feel desperate at this point. She was now taking days off work. She didn't feel she could tell her boss what the problem was. And her husband, who had been very supportive, was saying things like, all my friends' wives are on HRT and they're all feeling better, why aren't you? So this is the point that I ordered some blood tests on her. I ordered a serum estradiol and a free androgen index. And her serum estradiol level returned at 107 and her free androgen index at 0.7. Now, I will go through in more detail on a later slide what these figures mean. But the idea is that if we're giving a woman estrogen at a fixed dose every day, then through the skin, then she should be reaching a steady state serum level. And what I didn't know when I was a GP is that there's about a 10-fold variation in the way that women absorb drugs through the skin for reasons we don't understand. And some women can be really very poor absorbers. And the idea of doing the estradiol level at this stage is to just kind of keep sure that the woman is absorbing her estrogen in some shape or form. And we try to get the ladies at least over the threshold of having a serum level of at least over 250 to 300. So it was quite clear that Amira wasn't feeling any better, because actually, although I was giving her transdermal estrogen, she actually wasn't absorbing it very well. And so I suggested that she increased her dose. Now, at this point, I was going beyond the licensed dose, which is something that I had never done before as a GP. And I planned to see her again in 3 months' time with another blood test. So 3 months later, her blood test had come up a little bit, up to about 235. She was feeling a bit better. And I decided we needed to go higher. So I put the bit up to 8 pumps. But for any of you that have used HRT or had a little play with any placebo bottles, it's quite hard to fit 8 pumps around your body in a day. And so we decided to go with an estrogen patch. Again, something that I didn't know as a GP is that Estradot are the littlest patches, Everal are the next biggest ones, and the Estraderm are really quite large and unpleasant. So 2 little Estradot patches, and she was happy with that. So 3 months later, she was feeling fantastic. We quite often in the clinic record the verbatim phrases that the ladies say, because somehow just to write "I'm feeling better" doesn't quite get the message across. And phrases like "I've got my life back," "I feel normal again," "I can't believe the difference" are phrases that we hear quite a lot when we've been successful with HRT. So her menopause symptom questionnaire score was now 13. And she had a nice estradiol level well above the threshold. She still wasn't feeling very interested in sex. And this is the point that we discussed adding some testosterone. It is possible to add testosterone right at the beginning. My own personal view is I quite like to do things one at a time so that if something upsets somebody, we know what's causing the problem. At this point, we weren't going to need to do any more estrogen tests because we don't use the blood test to check that the level is high enough, as in that there's a sort of a maximum that we shouldn't go over. We just want to know that we've got them over the doorstep and that they actually are absorbing it. So at this point, Amira started some testosterone, and I saw her 3 months down the line. She was really feeling pretty good then. We monitor the free androgen index at 3 months after starting testosterone, because that's the way that we check that we're keeping a woman's testosterone level in the female physiological range. We aim to keep it between usually 2 and 3 is ideal. If it's lower, but the woman feels good, that's fine. But we certainly don't want it to be any higher than 5. She was feeling really good, and she was now established on 200 microgram patches, her Utrogestan and her Androfem. There's no evidence that if you give them a higher than licensed dose of estrogen that they need any change to the progesterone dosage. So Amira was happy, I was happy, and I thought this would be a good case to discuss. A couple of points I think it raises is, again, the obvious one about the perimenopause. You can be perimenopausal and still have periods. It's very common, and often the periods get heavier as you go into the perimenopause. If you think about the average age of the menopause being 51, some ladies will start at 45. I had my own menopause at 42. So in fact, I was probably perimenopausal in my late 30s. When to use blood tests? Again, lots of ladies ask us to have their blood tests done, and I'm sure many of us have done blood tests when we know that we didn't really need to. But I thought it would be worth just going through when it's useful and when it's not. I have never prescribed estrogen above the licensed dose when I was a GP. And I suspect when we are sending letters to GPs asking them if they're willing to prescribe higher than the licensed dose for women, they may feel a little bit unsure. So I wanted to just talk about that. And also just to finish off with a slight word about primary ovarian insufficiency. Again, just to make a mention of something that I wasn't really very aware of when I was a GP. So when a blood test useful? So basically, we check estradiol levels to keep sure that we've got them over the therapeutic threshold, that they're achieving a serum level of at least 250 to 300. You don't need to keep on testing it. Thereafter, doses are adjusted according to their symptoms, but it does show up women who are not absorbing very well. And this is much, much commoner occurrence than I ever imagined it would be. We also use blood tests to check that testosterone is staying in the physiologically female range. As I mentioned before, it's the free androgen index, which until I started to work in the menopause clinic, I never really understood what it was properly. But we aim to keep it between 2 and 3 and certainly no more than 5. We do that after 3 months, after a dose increase, and thereafter annually. The other thing I think it's good that we are GPs working in the menopause clinic is that not everybody that's tired and putting on weight and feeling miserable is menopausal. You know, just like alcoholics get other things wrong with them, menopausal women can have more than one thing wrong with them. And it is good to be able to keep sure that we have checked for things like anemia, diabetes, celiac, thyroid, and with baseline blood. So they can be certainly useful for that. And they are particularly useful for the diagnosis of primary ovarian insufficiency. So when are they actually not useful? And I think Amira is a good example of when they're not useful. I have definitely done blood tests and done FSHs on ladies when I knew the guidance was that I didn't need to do it, but I just couldn't resist because I just didn't feel confident in making a diagnosis of the perimenopause when I was sitting alone in my room in general practice. The ladies can be quite insistent that they want to have their blood tests done, and it can be quite difficult to persuade them that actually they don't need them, and they're really not useful. As you go into the perimenopause, your hormones start going up and down like a roller coaster. So what's happening on Monday might not be the same thing on Wednesday, and therefore the results will really, really be misleading and aren't helpful. It's also worth pointing out that serum estradiol levels are not accurate if you're taking oral estrogen or if you're taking the Lenzetto, which is the estrogen spray. So that's an example of when blood tests aren't useful. With blood estrogen levels, again, just to say, it's just about getting them over that threshold into a therapeutic zone. There is quite a big variation in how women absorb through the skin. And when we're thinking about prescribing off license, it's not really about the dose we're giving them, it's how much is getting into their circulation. So it should be at least over 250, but thereafter you just adjust by symptoms. When we go off-piste or off-license and prescribed higher doses, we're not just doing it in a sort of a willy-nilly, let's give this lady some more sort of way. We are being guided by the fact that we have evidence that they're actually not absorbing it. For any of you that are as old as I am, I remember going to a lecture with Professor Studd probably 25, 30 years ago, where he was really using or advocating for really high doses of estrogen in younger women. And I remember thinking, wow, I don't think anyone's going to be brave enough to do that. But I think now we actually have the evidence as to why this is needed, which makes us all feel a little bit more comfortable. And again, I have mentioned that if we are going to go with higher than the licensed dose, there isn't any evidence that the dose of progesterone needs to be increased. So feeling a little bit uncomfortable when we get that letter asking us to prescribe something with our GP hats on that we're not really used to. I think that is a very good reaction in GPs. We have to be very careful. We're taking responsibility for what we prescribe. And if we don't feel confident or don't understand why we're doing it, then to be wary is a good thing. But with estrogen, we are guided by the serum levels. And this is something that we do for transdermal estrogen. So the maximum licensed doses, estrogel is 4 pumps, Sandrina is 2 milligrams, and the patches are all 100 micrograms. But it's worth remembering there are quite a lot of drugs that we don't think too carefully about that actually we use completely off license. Amitriptyline for migraine and pain. We use higher doses now of cetirizine for hay fever and allergy, and the use now of candesartan for migraine. So when we in the clinic are suggesting that we use higher doses, or if you know you're in general practice and doing these tests, you are approaching it scientifically in a proper evaluated way. And of course, we need to remember that you can't really have too high an estrogen level, because in a normal premenopausal women, there are times when their estrogen levels at certain parts of the cycle are going to be way up in the thousands. So it is quite physiological at times for us to have quite high estrogen levels, and women will react differently. I just thought I'd mention a little bit about testosterone. Although we used symptoms to kind of adjust the dose of estrogen, with testosterone, we need to be very careful that we're keeping sure the woman is in the female physiological range. Testosterone safety data is only for use up to 2 years, but most ladies that take it are happy to carry on for much, much longer than that, on the basis that we are only replacing physiological levels. I myself have been on testosterone now for, can't remember, 5, 6 years. NICE do recommend that you check the baseline level beforehand. We often don't in the clinic, but that may be because we are dealing with ladies who are very clearly menopausal. But we do check it at 3 months after starting, after a dose change, and then annually. And again, I mentioned there that these are the figures that we're aiming for, the free androgen index. Now, not all clinics, not all laboratories will do the free androgen index for you. So I have this written on my desk with a post-it note. You can actually calculate it yourself by the ratio of the total testosterone divided by the serum hormone binding globulin in the same units and multiply it by 100. I've mentioned about the testosterone safety data only being for 2 years, but it is thought to be very safe. It doesn't cause an increase in blood pressure, doesn't do any bad things to your cholesterol, it's not known to have any impact on breast cancer risk or on your endometrium. Women are surprised when you say testosterone because they think of that being a male hormone, which indeed men do have more of it than we do. But a normal pair of functioning ovaries produces about 3 times as much testosterone as it does estrogen. So it is part of our normal physiological hormone profile. Side effects of testosterone, the common one which is quoted is increased hair growth at the site of application. And for that reason, we usually recommend, or News and Health usually recommend, that you apply it to the back of the thigh or the buttock, because there are less hair follicles there. I personally have never come across anybody that's ever had increased hair growth at the site of application. And in fact, I apply it to my wrists like perfume, and I can vouch I'm not like a hairy monster. So in general, side effects of testosterone really are very rare, but those are the ones that you could imagine have occurred very, very rarely. So testosterone is really pretty safe. It's not quite as quick at working as estrogen. Women sometimes, you know, you say to a lady that testosterone is good for all the things that estrogen is good for. It helps with cognition, with muscle strength, with fatigue. The one they've heard about and that they remember is that it's good for libido. And it probably is better for libido than estrogen. But what is often a bit disappointing is it doesn't seem to work quite as quickly as estrogen. So it can take up to 6 months really before testosterone's really starting to make you feel more sexually inclined. But it is worth sticking with it because it does work. And you can titrate the dose according to the symptoms, as long as you're keeping an eye on the free androgen index and keeping sure it's not going too high. Sometimes ladies have a raised serum hormone binding globulin or a low serum hormone binding globulin. And I've just put some causes in there. So if that does crop up on the blood test, you kind of know what to check for. And a raised free androgen index in a woman who is truly postmenopausal is a significant finding worthy of further investigation, suggesting an ovarian or adrenal disorder. Whenever I used to do those kind of, you know, hormone profiles on ladies in general practice, I always used to hope the pathologist had given me a description of what they meant, because I found them quite difficult to understand. But since working in the menopause clinic, I found this kind of simple approach to understanding what I should be looking at quite helpful. So this is just to explain the obvious, really, that I'm sure everybody knows. Having a menopause under 30 is classed as premature ovarian insufficiency. It's about 1 in 1,000 women, but it's also premature ovarian insufficiency if it's happening under 40. And the thing I didn't know in general practice is that actually it's much, much commoner than I thought it was. I thought it was really quite unusual. But 1 in 100 doesn't seem very unusual to me. And it may well be that in the past I have missed it in ladies. And of course, under 45 is just classed as an early menopause. So I thought I'd just spend 2 seconds, a few slides, just in case you want to just take this in. Primary ovarian insufficiency. It's not unusual. Some women don't even have any symptoms, and often the symptoms can be quite psychological, more so, rather than all the flushes and the sweats that we might think of in menopausal ladies. The standards say that you should do, this is a place when blood tests can be useful, 2 FSH levels, probably over 40, 4 weeks apart. However, the FSH levels are not always shown to be that accurate, and there is some variation as to what level the different authorities say counts as a diagnosis. So sometimes, in fact, it wouldn't be unreasonable to skip the blood test if you feel very convinced and just try some HRT. Because if the lady isn't perimenopausal, then the HRT isn't going to have much effect. And obviously, there are some ladies who go through a very early menopause associated with chromosomal problems that then need investigation. Again, treatment shouldn't be delayed. These ladies are at very significantly increased risk of osteoporosis and heart disease. So the treatment for them is not simply to make life better for them and pleasant and avoid symptoms. It's really about improving their long-term health. I've mentioned that about the blood tests. It's a little bit difficult to know, is it over 40, is it over 30? But I think the main thing is just to maybe remember that it is commoner than we think, and to look it up and decide what to do if you think you might have a lady that might have premature ovarian insufficiency. Obviously the treatments, we know HRT. It is important to keep sure that these women really are absorbing enough estrogen to get them over the threshold to maintain levels that are good for bones and for their heart. Some ladies find that they feel more comfortable at this point taking a contraceptive because there's a small percentage of women with primary ovarian insufficiency that can still actually spontaneously get pregnant. And again, something I didn't know in general practice is that Cleara, the slightly newer oral contraceptive, is the one that is most natural and contains estradiol. So just be careful about fertility, although it may well be that ladies in this situation would be quite happy to be unexpectedly pregnant, because indeed HRT can actually improve fertility a little bit, as it gives the ovaries a little nudge and wakes them up for a little bit longer. The other thing to mention is that if a lady is taking HRT and doesn't use contraception and does get pregnant, there's no evidence that taking the HRT has done any harm to the developing baby. DEXA scans, remember, in these premature ladies, these ladies who go through early menopause or premature ovarian insufficiency. And don't forget to check things like cardiovascular risk, because this is where they get into trouble in the future. And that's all really. I think Amira probably just went through those points that I wanted to point out about when to do blood tests, when not to do blood tests, why we sometimes at News and Health prescribe doses that go above the licensed and how we do that, how we monitor testosterone, because I know some GPs can prescribe in some areas Testim and Testogel, and just primary ovarian insufficiency is commoner than we think. And it's just, worth having that in mind sometimes when we've got a bit of a conundrum in front of us. So that's all really. Thank you. Thank you everyone for listening. I'm happy to take any questions now.
Thanks very much, Karen. That was really interesting. Yeah, please put your questions into the Q&A box, right in the chat box if you want them to be asked. I have been asked to note that NICE do not recommend that baseline testosterone blood tests are taken. They don't say it has to be done before you start testosterone prescribing.
Oh, do they not? Okay, I thought they did. Sorry, Sharon.
Right, we'll go to the questions now. We have there's a few people that would like to know this. You mentioned about blood tests not being useful or the estradiol levels not accurate when using Lenzetto or with another oral preparation you mentioned. Could you just explain why not?
I was dreading somebody was going to ask me that. I can't explain why not. With Lenzetto, it's something to do with the molecule binding with something in the serum. And I don't know why it's not accurate with oral. I'm assuming it's something to do with the first pass effect that goes through the liver, but I can't answer that accurately. I'd like to say I'm a clinician and not a physiologist, so I just know that it's not accurate with the oral preparations.
That's fine. If anyone else knows a bit more information,
yeah, do please chip in if anybody knows.
I'll read it out. Okay, we've got a couple of other questions now. If someone needs contraception as well as HRT during perimenopause, which contraception would you recommend?
Yeah, so it's always really helpful when the husband's had a vasectomy. So that's good. I never ask the question, but it always goes through my mind, is that the only person you're having sex with? But I don't say that because that would be very improper to say that. But it is just worth bearing that in mind, that you point out to the lady that HRT is not contraceptive. If she has a Mirena coil in, or she'd like to have a Mirena coil, then that's absolutely brilliant, because it takes her periods away. It effectively means she's almost on estrogen only HRT, which gives you an even lower risk of breast cancer than women who are not taking HRT at all. But if she needs contraception, then what we would usually do is suggest that she takes some Cerazette alongside her HRT, but she would still need the Utrogestan as well, because Utrogestan is not enough to be contraceptive, but the Cerazette is not thought to be enough to give the endometrial protection. So she can take Cerazette alongside the ordinary body identical HRT.
Great, thank you. I've got a response from Louise Newson about the
thank you, Louise.
Oral estrogen gets metabolized to other types of estrogen as well as estradiol, so that's why it's not accurate.
Perfect, thank you. So I've learned something tonight too, thank you.
And also baseline testosterone bloods are not always necessary. They ran an audit of baseline bloods in the clinic before prescribing testosterone, and they were always low. So I think that's why. Okay, we'll go to some other questions now. Some perimenopausal ladies have estradiol more than 1,000. I have had different advice with menopausal clinics saying it's okay and some saying it's not. What do you do?
Just say that question again, Shona.
Some perimenopausal ladies have estradiol that's more than 1,000. I've had different advice with menopausal clinics saying it's okay and done saying not.
Okay. I'm assuming that means that the blood test has been done before the lady's on HRT, suggesting that there might be a high estrogen level at that point. What I would think about that would be is that I wouldn't do blood tests on a lady before I started the HRT, because she could have an estrogen level of 1,000 on a Monday and 40 on a Friday, because estrogen levels can go very high and very low and very high and up and down in that perimenopausal phase. So the blood tests really are totally unhelpful. I don't know what the other menopause clinics have said, or if there's Louise is online, what she'd say, but I wouldn't have thought blood tests are helpful in that phase of assessment.
Thank you. How long after cessation of contraception for POI would we leave before doing a BT blood test?
Just sorry again, say that again, Shona.
How long after cessation of contraception for POI would we leave before doing a BT?
A blood test. I would say probably at least 6 weeks.
Would you consider a lady with long-term amenorrhea due to eating disorders to have POI? Should we be offering HRT to this population?
Oh, that's a good question. I think we probably should. Ladies who have got anorexia and who are a low BMI and low estrogen levels, who are not menstruating, are at increased risk of osteoporosis and cardiac disease. So it would be very common to offer these ladies HRT. Whether or not we would classify it as primary ovarian insufficiency, because that is more a sort of a genetically determined thing that's happening to the normal woman. But if it's an eating disorder, then I think these ladies should be having HRT or be on the contraceptive pill, but should have some estrogen to try to protect their bones if you can't get their BMI up. But I might not classify that technically as POI.
We have had a comment from Sarah Ball estradiol levels usually go up to 1500-ish at ovulation. So in perimenopause, it is not uncommon to get higher levels if on HRT, and this is normal as long as the symptoms are well controlled. Okay, back to the questions. Do you talk to perimenopausal women about whether they will need to reduce their transdermal estrogen later in life? Is this something that is likely as they age?
Okay, I think the doses of estrogen that's needed to control symptoms is very individual from one woman to another. There isn't any mandate that says that as a woman ages that she needs to reduce her estrogen dosages. So if her symptoms start to settle and she doesn't feel she needs this higher dose, and she can reduce the dose, as long as she's staying over the threshold to keep her bone health good, then she can reduce the dose. But if she continues to be symptomatic, there's no reason why she can't continue to have the doses that are adequate to control her symptoms. We are only maintaining her physiologically natural state for longer than nature intended. It's difficult to kind of remind ourselves of that, is that we're only extending what nature intended for that woman.
Thank you. We have a question just asking whether if you go higher than the licensed dose estrogen, whether you've already mentioned that you don't necessarily need to increase the progesterone. Somebody thought the BMS advised that if you're going higher than licensed dose, that you would need to increase the progesterone dose.
This is maybe where Louise might want to comment, but I'm not aware that that's the case. There isn't any evidence for that. And it's certainly not something that we do routinely in the clinic. Yeah, again, it's kind of based on this kind of belief that we have that estrogen is somehow bad for us and is putting us at a lot of risk of breast cancer and blood clots and things, which when you do a deep dive into that, is a belief and nothing much more than that, really. And I heard a very interesting quote the other day that said, you know, if you tell people that there's a man in the sky that's controlling our lives and cares for us, most people will believe it. If you tell people that the paint is wet, most people need to touch it to check. There's a lot of evidence that actually there is not the great connection between estrogen at all and breast cancer that we have come to believe. And therefore this kind of belief that it's got to be reduced or it's got to be the minimum dose possible is not based on evidence. And it's quite difficult sometimes to dispel that from our minds.
Thank you. Lucy, if you are there, if you could put Louise's mic on, she would like to say something at this point.
Thank you, Louise.
That's all right. Can you hear me?
Yeah.
Yes.
Oh, thank you. Just to say, absolutely brilliant talk. You're absolutely right. Now, there's two. There's mainly that women increase the dose of their hang on, let me just undo my camera so you can see that I'm a real person. There's two reasons why I don't rush and increase Utrogestan. I know the BMS say it, but it's not based on evidence. We don't have any evidence at all, but we're following up our ladies that do have higher levels, or higher doses. What it is when we increase dose is it's not just about increasing absorption, it's about the way that it gets through our bodies. So for example, I've always used more than a licensed dose, because when I used 100 microgram patch, I was still getting a lot of symptoms, including night sweats, so estrogen deficient symptoms, and my estradiol levels was 110, which is very low. Even using 2 patches, it only went up to 260 odd, so still lowish, and I was still getting symptoms. But my patches crinkle a bit, so I'm not absorbing them all properly. I've seen ladies with Everol patches, 50 microgram patches, and their level 600, so they probably absorb a lot better. So it's not always the dose that we put on our skin, it's how much we absorb is the important thing. And as Karen rightly says, sometimes doing estradiol levels can be really important for that. what we always say to patients, whether they're on a low dose, a normal dose, or a higher than licensed dose, is report if they have any bleeding, especially if it persists or it's constant or it appears after the first 3 to 6 months of starting HRT. And we'll always investigate these women, and we follow up the women who have been investigated to see. And we have really we've got a lot of patients now, and we've had 2 document cases of endometrial cancer, and these are both women who have come with bleeding from other clinics, actually, from bioidentical clinics where they're using transdermal progesterone. So we're collecting the data so we can see, but I wouldn't routinely increase progesterone levels, progesterone doses, just because we're using higher than licensed doses, because it's about absorption through the skin rather than what's happening. And some women on lower doses actually have more breakthrough bleeding, and you increase the dose of estrogen and then their endometrium settles down. So this is why individualized care is so important here as well. So just while I'm on the screen, and I will go because I don't want to steal Karen's thunder, is the reason that we don't do baseline testosterone levels is that we did a big audit before COVID, so it was a couple of years ago now, of all our patients, because we did routinely do testosterone. We did testosterone-free and SHBG on all our patients before starting testosterone. Perimenopausal and menopausal women. When we did levels, they were always low, and so we made an executive decision actually that we will offer it if women want to know how low their level is, but actually it wouldn't change our management. And it's very difficult, isn't it? If someone's got a low level, is that causing their symptoms? Obviously we've got no way of knowing. We always monitor their blood levels, so we do it 3 or 4 months after starting testosterone and then annually thereafter, because I feel it's important to make sure they're in a physiological level. But as Karen says, we don't have hairy bearded monster patients, and actually when we do measure levels, more commonly than not we still see low free androgen index, and if women are well on their low level, then that's fine, and it does vary as well. So we go on the patient's symptoms more than levels. I actually found that my free androgen index is only 0.5, so everyone's horrified to think if I increase it how far my brain might work, but I feel fine, so I'm not going to increase it. So there is always some fluctuation, and we can get caught out with these high levels of estradiol, especially in perimenopausal women. We've seen levels of 2,000-3,000 sometimes in women. We reduce their dose a bit and they feel worse, and we know that there's diurnal variation, there's variation for days. So we try not to do too many estradiol levels, especially in perimenopausal women. Also, to add, as Karen quite rightly says, estradiol doesn't cause breast cancer at all. We know from WHI study, women on estrogen only have a 22% lower risk of developing breast cancer, 40% lower mortality from breast cancer. Estrogen is very anti-inflammatory on our body. In our bodies, and if you think pregnant women, their levels of estradiol are 10 to 20,000, so a lot higher than the 1,000 that someone mentioned. So look at our patients, see what their symptoms are and not worry about their numbers associated. So I hope that's reassuring.
Thanks, Louise.
Thanks, Louise.
Whilst we were on the subject of testosterone there, one of the questions has been, can you give an example of how to titrate testosterone?
Yes, I can. So, well, we tend to use in the clinic Androfem, which comes in a tube. There we go. Comes in a tube, and it is made in Australia, and it's licensed in Australia for women, and it is only available privately. But there isn't any reason why a GP can't put this on a private prescription for their patients. The reason we like it is because it's quite easy to dose. So it's 0.5 ml a day. It comes with a little syringe, and what we say to the ladies is measure it for a couple of times until you get the idea of what a 0.5 ml looks like. And if you can see 0.5 ml sort of looks a bit like the size of a butter bean or an edamame bean, and they use that once a day. If you're using something like Testim or Testogel, because this is hand cream, by the way, and not real testosterone, unfortunately, but never mind. If you're using Testim or Testogel, which come in a sachet, the men would use a whole sachet a day, whereas for the ladies, they have to make it last somewhere between sort of 6 to 10 days, depending which sachet you're using. And it can be a bit more fiddly to dose, which is not only inconvenient for them, but it also means that it's far easier to kind of get a bit mixed up and you can't quite remember when did I start it and how many days it's supposed to last, and therefore there's more possibility that they don't get the dosage right. The other testosterone that we can use in general practice in some areas is Tostran, which again has a rather strange dosing method of either half a pump a day or one pump every other day. And again, women can get mixed up with how to take it. And did I take it 2 days ago, or shall I have another pump? And again, it just allows potentially the woman to be either giving themselves too much or too little. So if our ladies start on 0.5 ml of this, and we check their free androgen index after 3 months and it's still very low and they're still very symptomatic, because as Louise says, if they feel better, even though their FAI is low, keep them where they are, because all of us need different amounts of our hormones to make us feel good. But if they're still feeling symptomatic, then we would put it up to 0.75 and then repeat the process in 3 months' time. Is that okay? Does that help? It seems very strange answering questions to my own face and a sort of a screen with my presentation on it, but I can't see whether the person's nodding that that's an okay answer or not, but fingers crossed.
Sounded good to me, Karen.
Okay.
I have another question here from Liz. I have seen several perimenopausal women who are certain the same estrogen they've been started on has made them feel lower in mood. Can this happen, and does it tend to settle?
Well, I think some women that start HRT do feel worse. My first thoughts with that would be is that if they are feeling worse, it may be that it's the progesterone part which is actually upsetting them, because they're far more likely to be intolerant to the progesterone element than they are to the estrogen. So how we would approach that in the clinic would be to start to adjust the progesterone and either give it by a different route, so either give it vaginally if we're using Utrogestan, or to try different sorts of progesterone. The other thing I learned in the clinic is that, you know, a woman's not going to come to any serious harm to just take some estrogen for a month or two on its own, and then have the progesterone. And that really does help you work out which is it that's making her feel lower. Whereas, you know, with my GP hat on, I used to get a huge rush of adrenaline if I realized that I'd had a lady without her progesterone for a month and I thought I'd killed her. But actually, it's quite safe to take progesterone on its own for a couple of months. And then you can move into giving her progesterone later. So it's the progesterone probably that's making her lower, not the estrogen, I would say. Okay,
we do have a question about the signs and management of progesterone intolerance. You've kind of said there what you would do if you knew for sure that's what.
Yes. So what I thought was that would be really good for another case maybe next time. So with progesterone intolerance, what we would usually do is change the route of administration. And we all find this a little bit bizarre and the patients find it bizarre. But what we recommend is that instead of taking the oral capsule, you insert it at half the dose vaginally. So if for a cyclical regime, you're using 2 capsules from day 14 to 28, you insert 1 capsule from day 14 to 28 vaginally. And so it's working like a pessary, really. If you're taking 1 Utrogestan every night on a continuous regime, you would use 1 capsule every other night. And therefore you're getting less serum levels, lower serum levels of progesterone, which hopefully will solve the intolerance. If that doesn't work, we sometimes try Cyclogest or Lutogest, alternative progesterone pessaries. In more extreme cases, I mean, it's not that unusual to have ladies who are so progesterone intolerant that when they're taking it, they're at the point of feeling suicidal, and really you've got to balance the benefits versus the risks. And for ladies like that, sometimes we will use a regime where they take estrogen for 3 months continuously, with then 2 weeks of progesterone 4 times a year, and safety net that with an annual ultrasound scan to check the endometrial thickness. Again, it's all off license, but we explain to the ladies why we're doing that. And again, it's a balance of the benefits for them versus the risks.
We have a question here along those lines. If a 54-year-old woman has vaginal bleeding with using estrogel and Utrogestan 100 milligrams alternate days vaginally, would it be reasonable to step up the Utrogestan to daily vaginally?
Yes, absolutely it would. And sometimes if a lady is on, say, oral Utrogestan 1 a day, on a continuous regime and she's having bleeding, then you can put it up to 200 milligrams, 2 capsules, say for 3 months, and that will sometimes settle things down. But we would only accept vaginal bleeding as being okay, certainly no more than 6 months from starting HRT or a significant dose change, and would be very quick to do a scan. A lot of these ladies who have fiddly bleeding turn out to have something like an endometrial polyp that's the problem. Again, I know in general practice, some of the scanning departments now have got regulations about who they'll scan and who they won't. My own view is that scans aren't expensive, they're not unpleasant for a lady to have, and the sort of things that you're looking for, if diagnosed early, are very curative, and really therefore I have a very low threshold for doing scans in the clinic and in general practice if needed. The opposition comes from the NHS, who don't want you to do any tests on anybody and then blame you when you miss the diagnosis.
Okay, I'm just looking for some topics that we haven't covered yet. I think we'll just do 1 or 2 more questions. We have a comment and a question here. I've seen a woman in her early 40s with perimenopausal/early menopausal still bleeding in the last week. One of the issues with doing FSH times 2 is that if menopause is confirmed, then women can stop desogestrel after 2 years. But if we don't have a definite date and treat as perimenopause and is on a cyclical regime, then we tend to have to use it much longer. We talked this through and she preferred to have a second FSH before starting HRT. My understanding is that women under 50 can stop contraception 2 years after menopause, whether that is amenorrhea or 2 times FSH being under more than 40. What do you think?
Gosh, that was a complicated question. So I'll say what I think about contraception. So 2 years amenorrhea under the age of 50, you're safe. 1 year over the age of 50, you're safe. Over 55, it's very rare to conceive spontaneously, but not impossible if you're still having periods up to that point, but very, very rare. If you don't know where the woman is with her amenorrhea, then if you get 2 raised FSHs, I think it's 6 weeks apart, over 40, different laboratories often quote different things. You can count that as the marker in the sand for when she's kind of gone into her menopause and start counting from there where the 2 years or the 1 year starts. For most women, you know, getting pregnant in their late 40s, early 50s is a complete and utter nightmare. And so generally, I would always say it's better safe than sorry. And if you're not sure, then just to keep the contraceptive going for a little while.
Brilliant, thank you. I think we'll have to stop there with the questions, Karen. Thank you so much for answering all of those. You've done a brilliant job, and thanks to everybody for asking so many interesting questions. It's been a really useful part of the session.
Thank you.
Brilliant.
Okay, thank you everybody, and thanks to Louise and Sarah for helping me.
Thanks, Karen. So
Okay.
those of you that have joined us this evening, you should all get an email in the next day or 2 from 14 Fish that will have a certificate saying that you've been on this session if you need it for your log or CPD. It'll also ask you for any feedback that you might have, so we'd be really grateful if you've got any comments or questions or feedback you'd like to give us about these sessions. And also we're always looking for volunteers who are willing to be brave like Karen and present a case for us for next time. That would be fantastic. The next event that we have is next week on Wednesday, the 15th of June, and it's going to be a webinar on bleeding on HRT, which we've just talked about a little bit. And the speaker will be Claire Mellon, a well-known obstetrician and gynecologist in London. So that will be a really good webinar next week. And I also just want to draw your attention to an exciting event that we've got later this year. As the Society, we're co-hosting our first conference in Stratford with Women in Medicine International Network. And the theme of the conference is going to be creating an environment for women to thrive in medicine. You can find out more about the fantastic programme that's been arranged for the 2 days in September if you go to 14 Fish and look under events, and it's open now for booking, so have a look at that and sign up for that conference. It will be a really good time. So that's it from all of us here until the webinar next week. Many thanks for joining us all and for participating in our question and answer session, and I hope you enjoy the rest of your evening. Thank you.
Thank you everybody.